In today's video, we'll discuss about chronic renal failure. So, first of all, covering the definition of chronic renal failure, it is the slow, insidious, irreversible deterioration of renal function resulting in development of clinical syndrome of uremia manifested by hematological, endocrinal, metabolic, excretory, and neurological abnormalities. To remember this, remember the acronym HEMAN. So, hematological, endocrinal, metabolic, and excretory neurological. Now, this is chronic renal failure. This is slow, insidious, irreversible deterioration of the renal function, resulting in the development of the clinical syndrome of uremia, manifested by all these abnormalities. Now, to what condition can you actually call it a chronic kidney disease? Now, whenever there is a kidney damage, it can be functional or structural with decreased GFR, that is 60 ml per minute, persisting for more than 3 months, you will call it as chronic kidney disease. Now, the hallmarks of chronic renal failure is decrease in GFR, obviously, and albuminuria. Now, coming on to the causes. For causes, as I gave the acronym before, now I'll give you an acronym. There is a YouTuber called as no Caroline Girvan. Okay, and she's on YouTube. So YouTube is an OTT platform, right? So remember this. She's a fitness influencer, just for reference. So over here, why am I telling this? Just remember this and this alphabet from it. Okay, now coming on to the first cause, which is the congenital cause. Okay, for congenital cause, we have Alport syndrome and polycystic disease of kidney. Okay, now coming on to the G. By G, you will remember glomerular disease. Okay, for glomerular disease, we have proliferative glomerulonephritis, crescentic glomerulonephritis, rapidly progressive, membranous, membranoproliferative glomerulonephritis. You can mention all of them. Now remember the V. By V, we have vascular diseases of kidney. Vascular diseases of kidney. In this, you have SLE, polyarthritis nodosa, and vasculitis. Okay, then OTT, okay, obstructive cause or the obstructive renal diseases. This is when there is a tumor or there is fibrosis. So benign enlargement of prostate. Also, there can occur a retroperitoneal fibrosis, or there can be any tumor present in pelvic region, pelvic tumor. Now, T, by T, remember that tubulointerstitial disease. Over here, you will mention tuberculosis of kidney. This is basically miliary type of tuberculosis, and chronic pyelonephritis. Okay, pyelonephritis. Okay, now coming on to the pathogenesis, what you'll see is, first of all, there will be progressive destruction, which will lead to nephron loss. Then there will be compensatory hypertrophy Then hyperfiltrations infiltration stage, in which the serum creatinine will be normal. Then there will be renal failure. Then there will be end stage renal disease. Okay. Now to remember the clinical features for the systems, we have one more. Suppose you have a gun, right, and you want to know the specifications, right? So just remember you have a gun. Okay, the gun, you spell the gun as this. Okay, and you want to know the specifications, because specifications are specs, so remember the spec. Okay, so for the first G, I have general. So in general, what we'll see in the symptoms is there will be fatigue, weakness, and lethargy. But over here in the signs, what you'll see is there will be a decrease in energy, so there will be shallow appearance, and the person might appear to be chronically ill or weak. Okay, right? Then another G, GIT. Okay, the most common that we all remember is nausea, vomiting, and anorexia. Whereas in signs, what you can see is gastritis and hematemesis. Okay, now the next G is for genitourinary. In genitourinary, we will see that there will be infections, also nocturia and erectile dysfunction. By the end, we have neurological. There will be a decrease in the awareness. From the S, remember skin. So in skin, remember pruritus, easy bruisability. In the signs, what you will observe is there will be a pallor of skin, pallor, dry skin, and you will see excoriation. Okay. Now coming on to the P, pulmonary. Pulmonary may the patient will observe cough, dyspnea. You will see rales and pulmonary embolism or pulmonary edema. So by E, we have the ENT. In ENT, the patient will see experience metallic taste and epistaxis, nose bleeding, and we will observe that there will be a urinous breath. Okay, this is seventh, right? So yeah, by C, yeah, C is for CVS. In CVS, what we'll see is their patient will experience retrosternal pain, and we will see that there is hypertension, pericardial rub, and there is cardiomegaly. Okay, now coming on to the next, the diagnosis. Now in diagnosis, first of all, we will consider some important diagnostic tools which are required for the diagnosis that there is chronic kidney disease. First of all, as I mentioned earlier, that there should be a history of kidney disease more than 3 months. Okay, history of pre-existing kidney disease for more than 3 months. Okay, then there is anemia, hypertension, all the abnormalities that I mentioned in the definition, just write all of them, as in UTI, GI symptoms. Okay, then renal osteodystrophy, abnormalities should be present. Then there should be a low fixed specific gravity. When I covered in that video where we discussed about the differences between acute renal failure and chronic renal failure, in acute I said that the specific gravity is high, and in chronic I said it is low, so remember this. Then there is a reduction in GFR, which is obvious. So then there is also you must consider the presence of hyaline renal failure, yeah, broad cell casts in urine. Also, when we do ultrasound, there should be small contracted kidneys. Okay, now coming on to the investigations. First of all, the foremost is the blood examination. In blood examination, we will see that there will be anemia and there will be a decrease in the erythropoietin production. Decreased erythropoietin production. Then blood biochemistry. In blood biochemistry, what you'll see is the creatinine, uric acid, and urea phosphate levels will be increased. Then in you will see the blood pH. In blood pH, the it will be low because of the metabolic acidosis. Then we will do the um, then we will do the urine examination. Urine examination, specific gravity will be low and there will be casts which will be present. Okay, then we will do GFR test, which will be obviously low. Then we might do chest x-ray. This will show cardiomegaly, then hypertension, pulmonary edema. Then we'll proceed to ECG. This will show us left ventricular hypertrophy. Then we will do ultrasound of kidneys, as I mentioned, small kidneys. But in some diseases, what we see is the kidneys are not small but they are enlarged. Such diseases are polycystic kidney disease, also diabetic neuropathy mein the size is increased. Okay, वैसे it is normally decreased. Okay, in chronic renal failure. Now coming on to the management. For management, what we'll see is, first of all, we need to find out the cause and reversible factors of uremia. Okay, now then we need to measure and limit the adverse effects of uremia. Then we need to find out the cases of stage 5, that is end stage renal disease, and we must give them supportive therapy, hemodialysis or transplantation, whatever is the call. Now on to the treatment. First of all, we will treat the underlying cause. For hypertension, we will give antihypertensive drugs, also salt and water restriction diet. We can, in antihypertensive, we can give ACE inhibitors, angiotensinogen receptor blockers like losartans and valsartans. Then we can give diuretics. Okay, alpha blockers. Also we can give more. Okay, now in diet should be around 1700 kilocalories. Okay, then 30 to 40 grams of protein is necessary. Then fluid replenishment is also carried out. Okay, it is restricted in the end stage. Then coming on to the anemia part. In anemia, we saw in the blood investigation. So we will give human erythropoietin recombinant. This is 50 units per kg 2 times a day. Okay, now we can also give darbepoetin. Now to treat metabolic acidosis, we will give sodium chloride. Okay, then to treat hyperkalemia, we must stop those drugs which spare the potassium. So as discussed earlier, insulin, calcium gluconate. Okay, for then coagulopathy, we will certainly give heparin. Then male erectile dysfunction, in this we will give phosphodiesterase inhibitors like tadalafil. For infection, we will give antibiotic prophylaxis. Then for the other, one more thing was left for renal osteodystrophy. For renal osteodystrophy, um, We will give Savlomer, Sinacylate, aluminum hydroxide gel. We can give vitamin D, okay, in the form of 125 dihydrox cholecalciferol. Then the another result of the treatment is dialysis. Okay, now for dialysis, the indications can be remembered by the acronym SAF. pH. Okay, so if there is severe metabolic acidosis, if there is acute renal failure, if there is an acute renal failure on chronic renal failure, if there is fluid overload, then if there is poisoning, if there is hyperkalemia. Okay, now complications. To remember the complications, remember a person named as Hamid. Hamid is having the complications of dialysis. Remember it in such a way. So Hamid, H for hypotension, bleeding, anaphylactic reaction, muscle clamps, air embolism, infection, HIV, okay, or hepatitis. D is for dialysis, disequilibrium, equilibrium syndrome. Okay, now if the treatment is not sufficient of dialysis, so we will consider giving renal transplantation. Okay, in renal transplantation, the kidney is taken from the cadaver or the donor or the sibling or the parent, and just given to the person who is getting from the, okay, the receiver, yeah. So the receiver. So renal transplantation is basically, in this what we do is we give long-term immunosuppressive drugs like prednisolone or cyclosporins. Okay, now why is this question very important? Because this question has certain dental implications. First of all, what we see is if there is a poor, the patient of the chronic renal failure will have a poor oral dental hygiene. Okay, so due to this, not lot of conditions like caries and many more will happen. First of all, when such a patient arrives, you must have the investigations already done. The routine tests should be performed. Whereas if there is a person who suffers, who's taking peritoneal dialysis, he or she is not contraindicated for a dental procedure. So the patient who has uremia, so he will also have bleeding tendencies. So even when you refer the drugs, you must avoid those drugs which have nephrotoxic effects, as in some of the aminoglycosides. Okay, then when we are giving the time of the dosage of the drugs, you must consider that there are certain dietary restrictions that the person has been following. Okay, so these are the certain implications that we have to keep in mind in point of view of with dentistry. So you can also mention them. So this is chronic renal failure. I hope you understood.